Good day everyone. Hi, it's me again, Nurse May. And in continuation of our head-to-toe assessment return demonstration, today's video will be all about the segment 3, wherein we are going to discuss the patient's cardiac aspect of the thorax, the upper extremities, and the abdomen. In assessing the cardiac aspect of the thorax, the first thing we are going to do is to position the patient in a semi-fowler position and move to the right side of the table or the bed. Then, we are going to check for apical pulse and then inspect the fourth and fifth intercostal space at the mid-clavicular line of the patient.
To help visualize the pulse better, we can repeat the process with the patient on her left side.
Then, we are going to palpate the apical pulse, even if it's not visible.
It should feel a short, gentle tap and should be palpable in an area about 1 centimeter by 2 centimeters.
After palpating the apical pulse, now we are going to systematically palpate the heart borders of our patient using the ball of our hands.
Starting with the sternoclavicular area, the aortic area, the pulmonic area, and the left ventricle area. We should note any vibrations or heaves. In auscultating for heart sounds, there are 3 different positions. These are the supine, the sitting up, and the lying on the left side.
Next, we will auscultate the heart at the second right intercostal space close to the sternum, along the left external border, in each intercostal space from the second through the fifth and the apex.
We must determine the patient's heart rate, rhythm, and listen for normal heart sounds as we auscultate using the bell and the diaphragm of the stethoscope. And listen for the normal heart sounds, S1 and S2. S2 is best heard at the base of the heart and correspond to pulmonic and aortic valve closure at the end of ventricular systole. S1 is best heard at the apex. It corresponds to mitral and tricuspid valve closure. Occurs almost simultaneously. We must also stay alert at abnormal heart sounds, such as S3, which may be a sign of a heart failure, and S4, a result from vibration caused by the blood striking the left ventricle.
Now, we are going to assess the patient's upper extremities. Throughout this assessment, we are going to note the range of motion of the arm of the patient, the muscle mass, and of course the strength of the arms of the patient. First, we'll assess the vascular system in the arm of the patient.
Then we are going to inspect the patient's hands. They should feel warm and should not detect lesions or edema.
Next, we will check the capillary refill time
by depressing a nail bed until it blanches. Then, quickly release the pressure. The nail bed should regain its normal color in 1 to 2 seconds.
And then, palpate the radial and bronchial pulses of the patient.
It should be equal, regular in rate and rhythm, and strong but bounding in amplitude.
Next, we are going to evaluate the arm sensory function of the patient. To assess for light touch, we are going to randomly touch the patient's arm using a cotton ball and instruct her to tell us once she felt it.
We must also remember that throughout the evaluation of the sensory function of the arm, we are going to follow these guidelines. We are going to instruct the patient to keep her eyes closed, scatter the stimuli, vary the pace, compare distal and proximal areas, compare both sides, and map areas of the sensory loss.
Now, we are going to assess the patient's pain sensation using a broken swab stick, wherein this is going to assess the sharpness and dullness of the sensation. As if that this is a swab stick, wherein this is the sharp part and this is the dull part, or not sharp.
We are going to instruct the patient to identify the sensation as we lightly touch her skin, and alternately touch the skin using the sharp and dull ends of the stick.
If the patient has trouble identifying the stimuli, we are going to assess the temperature sensation using a test tube of warm and cold water to the patient's arms, as if this is a test tube with cold and warm water.
We are going to assess her temperature sensation using a test tube of warm and cold water. In a similar way, we assess the patient's pain sensation.
Then now, we are going to assess the patient's vibration sensation. In testing the patient's vibration sensation, we are going to use a turning fork. Since I don't have any available here in our house, as if this is a turning fork.
To test, we are going to activate a tuning fork, then place its stem over a distal bony prominence such as the finger of the patient. Then instruct her to say now when the fork start vibrating and again when it stop vibrating.
The next thing we are going to do is to assess the patient's position sensation.
Then instruct the patient to close her eyes as we move one of her finger up and down, and instruct the patient to tell us which direction we are moving it.
Now, we are going to test the patient's touch discrimination using or with the four next test.
To assess the stereognosis, we are going to ask the patient to close her eyes and place a coin or any object in her hand, and ask her to identify it. Next, we are going to assess the graphesthesia, wherein we are going to trace a number on the patient's hands and ask her to identify it. Then we'll assess the toe point discrimination, wherein we are going to randomly touch two sharp objects to the patient's fingertips and then gradually decrease the distance between the two objects. Note the distance where she can no longer identify two separate points.
After we deliver the four different tests, now we are going to assess for extinction,
Wherein we are going to touch two corresponding parts of the patient's body at the same time and ask her to show where she was touched.
Now, we are going to test the motor function by assessing deep tendon reflexes of the patient.
We are going to start by testing the biceps reflex. First, we are going to place our thumb in the patient's bicep tendons and strike it with a reflex hammer. Then we are going to try the tricep reflex. As we support the patient's upper arm, we are going to strike the triceps tendon above the elbow. This should elicit forearm extension. And lastly, we are going to test the branchial and radialis reflex. Then we are going to strike the forearms 2 to 3 cm above the radial styloid process.
After, we are going to assess the cerebral function of the arm.
Then we are going to instruct the patient to pat her knees, palm facing upward, then downward. Then assess point-to-point localization using the finger-to-finger test. And lastly, have the patient touch our finger with her finger and touch her nose.
Also, we'll perform the finger-to-nose test.
Here we are going to instruct her to close her eyes and have her arms stretch out and touch her nose with one index finger then the other.
In continuation of our segmentary assessment, now we are going to assess the patient's abdomen. Before assessing the patient's abdomen, we are going to consider her history, and during the exam, we are going to observe the patient's face regularly for signs of pain and guarding. Next, we are going to inspect the patient's abdomen from the ribs to the symphysis pubis.
To highlight any bulges, we are going to shine a light across the abdomen toward us.
Then we are going to assess the umbilicus of the patient.
The umbilicus should be midline and inverted.
And now, we are going to auscultate the abdomen.
In auscultating the abdomen, we are going to begin by placing the stethoscope diaphragm lightly on the right lower quadrant. We are going to listen for at least 2 minutes. Then we are going to assess all bowel sounds in all quadrants and determine if the sounds is normal, hyperactive, hypoactive, or absent. Be sure to listen for 5 minutes before concluding that they are absent.
Now, we are going to auscultate for vascular sounds by switching to the bell of the stethoscope and listening over the
Aorta, renal arteries, iliac arteries, and femoral arteries.
Then, we are going to percuss in a systematic fashion,
Wherein we are going to hear dullness over the solid organs and tympani over the air-filled organs.
and then we are going to percuss each organs of the patient.
Beginning with the liver. To assess the liver, we are going to percuss from the right lung area down to the mid-clavicular line until we hear dullness. We are going to mark this point, which is the upper border of the liver. Then percuss up to mid-clavicular line from the umbilical level until we hear dullness. Mark this point too, which indicate the liver lower border. Measure the distance of the two. Mark to estimate the size of the liver, which should be 6 to 12 centimeter. Now we are going to assess the stomach by percussing over the left upper quadrant. Next, we are going to have the patient roll over the right side, then assist her spleen by percussing from the 6th rib down to the mid-axillary line, and then percuss at the lowest intercostal space in the anterior axillary line where we should hear tympani. Then we are going to percuss the bladder, starting with the point 5 cm above the symphysis pubis and continue to percuss downward. We should hear a tympani over an empty bladder and dullness over a full one. Next, we are going to lightly palpate the abdomen, avoiding only the tender areas. Using our fingertips, palpate the right lower quadrant and move clockwise to all 4 quadrants. Now we are going to switch to deep palpation following the same sequence, pushing 5 to 8 cm. Note the size, location, consistency, and mobility of the abdominal organs. If deep palpation proves difficult, such as an obese patient, we are going to use a manual palpation. To palpate the liver, we are going to slide our left hand under the patient along the 11th and 12th rib and push up. Then we are going to place our right hand on the right upper quadrant and push down under the right costal margin. Then we are going to ask the patient to take a deep breath and feel for the firm liver to move down with inspiration. Now, we are going to try to palpate the gallbladder using the regular technique we use for the liver. Normally, the gallbladder isn't palpable. Then we are going to palpate the spleen. We are going to reach over the patient and place our left hand behind her back at the 10 to 12 ribs and push up and place our right hand in the left costal margin as we push our right hand in and up toward the axilla. Then we are going to instruct the patient to take a deep breath, and normally the spleen is not palpable. If a bladder problem is suspected, we'll need to assess it, beginning with placing both hands in the midline, 2.5 cm above the symphysis pubis, and palpate in and upward direction until feel the edge of the bladder. A normal bladder may not be palpable. Now we are going to palpate the right kidney. Placing our left hand under the patient's waist below the 12th rib and our right hand directly above it, we are going to instruct our patient to take a deep breath and bring our hands together. If the kidney is palpable, we should feel a small round mass slide between our fingers. Then finally, we are going to palpate the aortic pulsation by placing our thumb and index finger left of the midline, estimated which should be 2.5 to 4 cm.
And finally, we are going to test the patient's abdominal superficial reflexes.
We are going to stroke the handle of the reflex hammer across her abdomen from the side to the midline. Normally, muscles would contract and umbilicus deviate towards the stroke area.